Here's a more advanced case. This is a patient that has some health risk factors, would like to try to consolidate the treatment into a single stage treatment. He is unhappy with his dentures. They're really unstable, so he's looking for some more of a stabilized fit. For those of you that are very comfortable with doing hybrid restorations, you're probably licking your chops now because we have beautiful ridges, nice attached tissue here. But with every one of these patients, when they come in with an inadequate set of dentures that don't dictate the ideal tooth position and so forth, we're going to get to the right spot and then work backwards. So this patient gets to a wax try-in, gets the vertical dimension right, the lip support right, everything's correct, and then we do our workup. And this is kind of tying a little bit of digital dentistry into what we're doing now in our practice. And you can see this is a double scan where we plan the implants. And I don't know if everybody in the room can see here, but there's an outline of the denture. And then you see his ridge, and the implant's placed at an adequate vertical position to allow enough restorative space for our framework, our materials, and a stable set of prosthesis that's not going to give us problems. And you can see that ridge is kind of pointy, and that implant's very subosseous, so we're going to have to remove bone. Where do we get our most stability with implants? We get it in the cortical bone, not the trabecular bone. So this is an actually important situation if we plan to do immediate loading, because we need to have stable implants if we're going to give them a teeth, but at the same time, we don't want to sacrifice the space for the definitive restoration. So when we do our digital planning, we can go into utilizing additive manufacturing to our advantage. This is a pretty neat template. It's a piggyback template. So this is actually what goes onto the bone. This is used to seat it, and this is used to place the implants. And then this right here is going to dictate our bone reduction. So here you see the patient actually using his upper denture now to bite the template into place, and then we do these lateral bone pins to hold it stable. So now we have the bone pins in place, the template's stable, we pull off that seating jig, and we're going to remove this bone here. So when we remove that bone, obviously we've removed some cortical bone, so we're going to want to place implants that are going to have a thread design that's going to kind of engage that bone in a manner that hopefully maintains that stability. But using a CT-guided approach is going to give us more precise osteotomies. It's going to take away from that vibration of free-handing something. It's going to give us a more accurate fit of these implants. So we have the potential, once these implants are placed, to maximize that primary stability and eventually immediately load it. So you can see the Osstell reading there of I gave you the lower number, 78, but it was getting 81 from the mesial. So when we got numbers like this with cross-arch splinting, we chose to do immediate load on this patient. Take into consideration we're opposing a conventional denture. We're on a patient that's older than younger, so he's not going to be putting forces on there that are detrimental. So we could see that we have high stability tied to the Osstell scale here. So here we have the temporary copings in place, everything's sutured, the denture gets jumped, and then back in the laboratory we go through the process of removing the flanges and rounding things off so the patient can maintain it. And this is, I guess, we've been doing this for over 15 years, but it's kind of become kind of mainstream in our practices now. You hear people talking about immediate restoration, different types of techniques and getting patients into teeth quicker and in a functional manner. And the Osstell plays a nice key part of this whole process, especially, like I said, working with surgeons that are going through that evaluation process. So we have 2-week follow-up.